Yeah. Hello, thank you for joining us for the CVL Science Luncheon series. And today it is my pleasure to welcome the fourth speaker of the series, Dr. Manish Jha. He's currently an assistant professor at UT Southwestern in the Center for Depression Research and Clinical Care, and also in the Department of Psychiatry. And after completing his medical degree in India, he completed his residency actually here in psychiatry at UT Southwestern, served in clinical practice for many years, specializing in serving patients with treatment-resistant depression with evidence-based intervention methods. And then now he's an assistant professor at UT Southwestern, and his clinical and translational research spans neuroimaging work, genetics, proteomics, randomized clinical trials. And today he's going to share something that I think is probably not well understood to us, but we probably have an idea, that irritability is an important facet of depression, and that is the focus of his talk today. So please join me in welcoming Dr. Jha.
Thank you. Thank you so much. I'll take off the mask because we are socially distanced. Thank you. I want to get started with the talk. So these are my lifetime disclosures. As you mentioned, I have done industry-sponsored research, clinical trials, so some of those are listed over here. I often also do CME presentations for which I have received honoraria. And then also recently started to be asked to be on consultancy work. So anything, I would be talking about ketamine a little bit in the talk today. And it is as enantiomer of ketamine, as ketamine is FDA approved, and I was part of the phase 3 studies. So that's could be a potential conflict to keep in mind. So this is the broad outline of the talk. I really want to walk through what is irritability, because that often would come up. It's still unclear in my head sometimes. And then as a clinician, the question to me has always been that, why should I be assessing for irritability? Like, it's not a core symptom, as we will see, for major depressive disorder. So I got bought into measuring 9 symptoms. Why should I be adding a 10th symptom? That was my approach. And then more recently, we looked at irritability and how it relates to suicidal ideation, and then wrapping it up with treatments. And some of our early efforts are understanding what the brain mechanisms are, which may be of interest to the group here. So first, what is irritability? So I do like this figure because it does bring up a lot of related constructs. So things such as impulsivity, anger, reactive aggression, they are all sort of like intertwined. And often when we ask people to answer questions and we ask them about frustration or anger or irritability, their responses often tend to be very similar. Well, I do want to tease out what's this proactive aggression, or sometimes like psychopathy or aggression related to that. That tends to be a bit different. However, animal models can sometimes be difficult to understand that, like where there are some aggression animal models where it kind of blends the reactive versus proactive ideas. So the simplest definition that I like for irritability is that it is, in a way, it's a trait. So sort of like blood pressure in everyone, right? But it's a trait that predisposes people to have anger more easily. So a reduced threshold for responding with anger. And classically, it's thought in the context of frustration. So expecting a reward and not getting it. In the context of frustration, getting angry easily is thought to be irritability. But recent work also shows that it's also in the context of threat. So both frustration and threat, those systems are involved, and we'll briefly touch upon that. It's really clinically relevant because we see irritability often associated with anxiety. So when we see patients, irritability and anxiety often exist together. So a simplistic way of thinking about it is the two angles of like fight or flight reflex. So irritability could predispose to both of that. And also it's thought that there are these like tonic components of irritability. So this irritable mood, and we'll get into that a little bit, which is sort of like baseline, and superimposed on that are the outbursts or temper tantrums. Now, these are much better detailed and understood for pediatric samples because there could be normative groups, right? A group over here if three people are sort of like out of the bound or getting angry more easily, that is easy to define in pediatric samples. In adults, that is often more difficult because we have better like prefrontal cortical control. So the behaviors tend to get suppressed sometimes. So don't read the whole table, but this is just like an intro to, there are all these different disorders in which irritability does occur. So it's truly a transdiagnostic feature. Like my work started with depression, but even there we are moving beyond just major depressive disorder. But often there is difficulty in conceptualization, and it's not unique to irritability. For example, people who study reward, anhedonia is often difficultly diagnosed. Even anxiety as a construct is broadly understood, but sometimes difficult to operationalize. Similarly, irritability is sometimes defined as mood, sometimes defined as behavior, sometimes explained, sometimes unexplained, persistent, episodic. So there is a lot of heterogeneity in how we conceptualize irritability. We also, at least from the clinical point of view, why this was relevant to me was that it's when we look at the diagnostic criteria for major depressive episode, irritability is unique that it is a criterion symptom for adolescents and youth, so below the age of 18. It can replace sadness or depressed mood as one of the criterion symptoms. So presence of irritability in the absence of sadness or depressed mood may be qualifying for diagnosis of major depressive disorder, but it's not for adults. So what that happens is that if you look at rating scales for depression, such as something developed here at UT Southwestern or in Dallas, a quick inventory, it's a 16-item scale. The adolescent version has a 17th item asking about irritability. So in what becomes a common practice is that irritability is on the mind of clinicians when they're seeing youths, children, like young adults, but when typically, like as an adult psychiatrist, I would not systematically ask for irritability because it was not a core symptom. However, studies have shown that there are about 40 to 50% of adults, when they are currently depressed, they do have significant irritability. So that's something to keep in mind, that just because the age changes from 17 to 18 doesn't mean that irritability stops being a feature of the illness. And again, this is not unique to this construct. We have seen this happen with illnesses such as ADHD, attention deficit hyperactivity disorder, where again, it was thought predominantly as a childhood disorder, and now we have better understanding and sometimes overdiagnosis, but at least we know that it may extend into adult years too. So how do we go about measuring irritability? So the problem is there aren't any good scales in adults. So we have used these 5 items, and I'm just putting these sentences on the screen up here because they were developed in the context of a completely different scale. But these 5 items sort of like went together in these 17-item scale. And as you can see, these are sort of like asking people to rate these sentences on the scale of strongly disagree to strongly agree. So like I would want people to just leave me alone. I feel very uptight. I find myself saying or doing things without thinking, which can be like a feature of impulsivity. So going back to those like Venn diagrams, so features that could be overlapping, and knowing is probably comes the closest to when we think of irritability, or saying that people get on my nerves easily. So again, these 5 sentences sort of go together. The other important aspect of the scale is that it asks people to rate from strongly disagree to strongly agree, which is different from a lot of symptom checklists when we do, where it's absence some days. And so the absence, the negative aspect, gets a bit more stretched out. So it allows for a more normal distribution of responses. So we see that even in healthy control individuals, there will be some normal distribution, whereas if you're administering a depression rating scale, in healthy controls, it's all zeros, right? Or maybe a few ones. So that allows us to get a better distribution of symptoms. So now, after talking about how do we go about measuring irritability, why should we be measuring it? So we have looked at it in a few different ways. So I start with talking about irritability at a visit and how it relates to psychosocial functioning. So in this particular study, this was a study of depressed individuals who were started on an antidepressant treatment. But at the baseline of this study, how was irritability related to impairments in psychosocial functioning? Okay, so my cursor is not obvious, but if you look at in the blue line is the irritability. So the higher levels of irritability were associated with more psychosocial function impairment, even after controlling for depression severity at the same visit. So suggesting that irritability independently is associated with poor social functioning. In this study, we looked at quality of life. So again, at baseline, how does irritability relate to features of the quality of life? So here the scale is opposite. So lower the value, poorer quality of life. So higher levels of irritability was associated with poorer quality of life, even after controlling for symptoms of depression. So in these two separate findings, and we did look at a few other samples also, where greater irritability was associated with poorer work productivity, poorer non-work related day-to-day activities. So it does have an impairing effect even after we control for other features of depression. Yeah.
Is this in the MDD patients alone or all samples?
So this one is in a stimulant use disorder sample. So STRIDE is a stimulant use disorder. Thanks for that question. Yeah. So
do you see these relationships in control participants as well?
So we don't have that large a control sample to answer that. We have looked at a really large, about 10,000 people who were screened for depression in primary care clinic and who screened positive. And there we found that higher irritability was associated with more work productivity impairments, more impairments in non-work related day-to-day activities. So, but we don't have like a large enough healthy control sample to answer that. So this is our data, but literature also supports several of these things. So this was a longitudinal study where people came in and they were then assessed at the index visit and followed up for up to 12 years. So irritability present at that index visit, so irritability or overt anger present at that visit was associated with higher likelihood of lifetime alcohol use disorder, higher likelihood of any anxiety-related disorder, and a higher likelihood of even antisocial personality disorder. So this, again, presence of irritability was associated with greater comorbidity, but relevant to the findings that I just showed, it was also associated with greater impairments over the next about 12 years follow-up, that there were poorer quality of life, greater functional impairment. So just to sort of like summarize all that I've talked so far is that irritability is common in adults with major depressive disorder, and presence of irritability at baseline predicts poorer outcomes in future. So that's something to keep in mind. So what happens, and our center led by Dr. Trivedi has a lot of treatment-related data. So what happens with irritability? So one of the key constructs about 2 decades ago was that irritability could be a feature of activation syndrome. So about in 2006, 2007, FDA added a black box warning to antidepressant medications that in some people, when they take antidepressant medication, there is a quote-unquote activation syndrome. People may become manic, and that then leads to a higher likelihood of suicidal ideation. And so all antidepressant medications have a black box warning that there could be a worsening of suicidal ideation when we start people on antidepressants. So and also there was this notion that some medications may worsen irritability more than others. So bupropion is a non-serotonergic antidepressant that's thought to be more activating. So we looked at this data, and what we found that about 5% of people had a big increase in their irritability symptoms when we start them on antidepressant treatment. And most of this increase happens within the first few weeks. So you see that within the week 4 is where 1 to 2% people are experiencing worsening of irritability. What we found was that during these first 6 weeks, if people had worsening of irritability, and for that matter, worsening of anxiety or worsening of insomnia, they were less likely to be better at week 12. So their likelihood of remission at week 12 was lower. So that early worsening of these symptoms predicted lower likelihood of subsequent treatment benefit in terms of their remission. So that led to this question that about 40 to 50% of people have depression, who with depression have irritability. What if their irritability does get better? So if with these treatments, does irritability get better, and what if it gets better? And what we found was that if you look at people during the first 4 weeks of treatment, those who have greater reduction in irritability. So we did a median split. So your red is less than median and blue is greater than equal to median. Those who had a greater than equal to median reduction in irritability symptoms, their likelihood of being better, so in remission at week 8, was almost twofold. So irritability, greater reduction in irritability was associated with higher likelihood of remission, higher likelihood of meaningful benefit. That was done. Now, a key question here is that irritability and depression are likely related. So as people are improving, we expect improvement in depressive symptoms also. So this result only makes sense if I can show that improvement in irritability independently predicts improvement after controlling for changes in depression. So what we did was it's small, but we made a very simple logistic regression model where it was at baseline symptom of depression, baseline symptom of irritability, baseline to week 4 change in symptom of depression, and baseline to week 4 change in symptom of irritability. The reason I put this equation up here is because now you can plug these numbers for any given person and you have a probability. And when you have a probability from one study, you can put it in another study and replicate how well the model performs. And that's what we did. What we found was that in one of the study, whatever we predicted, that probability was very well captured in another study. So ADA under the curve was about 0.8, which is probably as best as it gets with clinical symptoms in psychiatric prediction. So our hope with this was that we get to a stage where it becomes a clinical practice that as a clinician, when I'm seeing someone, I get their irritability measure, I get their depression severity measure, I plug those two numbers, and then I get a probability of remission or probability of no meaningful benefit that then I use in a shared decision making in a collaborative effort to make treatment decisions. So we replicated the same pattern in another Embark study that we'll talk about in just a little minute. And the model that was developed in COMET trial validated very well in this third sample of people with depression who were treated with either sertraline or placebo. So again, just summarizing this, that we offer a way in which irritability, is there a question? Just feel free to stop me. So irritability can be assessed easily, can be integrated in a measurement-based care paradigm where it can be used to improve predictive accuracy. So we did do those analyses that by including irritability, how well did our model perform, and those were all significant. There was improvement reclassification. So, okay. So then linking irritability to suicidal ideation. So when we published our paper on the clinical utility, one of the deputy editors of the journal wrote an editorial essentially telling us to look at developmental literature because we were in our lane of doing adult psychiatry work that we were not, or at least I wasn't very familiar with what was going on in the developmental literature, so pediatric studies. And what we found was that 2 studies, at least several studies, but these 2 I highlight, where irritability during earlier in life, so during childhood or adolescence, was more strongly associated with suicidal ideation or behavior later on in life. And in one of these studies, the Ori et al. Paper, actually depression or anxiety by itself in the absence of irritability wasn't associated with suicidal ideation or behavior during adolescence. Irritability by itself was. So suggesting that there may be a link between irritability and suicidal ideation. So we had, in several studies, we had a measure of active suicidal ideation. So again, these statements where people were asked to rate themselves on a strongly disagree to strongly agree scale. And these are pretty explicit statements about active suicidal ideation. So we had several studies where these were present. I discussed those studies briefly with you here, because they were very different. So COMET was a study where the idea was, do antidepressant combinations, how well do they compare to an antidepressant monotherapy? Embark was a randomized controlled trial that had a very extensive imaging and other biomarkers collected at baseline in week 1, and people were then randomized to either sertraline or placebo. And then SAMS was a study where people just received open label treatment with an SSRI that is indicated for depression. So these 3 very different samples. Embark was actually you're more similar to an industry-sponsored study. People were recruited as symptomatic volunteers. They sort of reached out to us to participate in the study. Comet and SAMS were people were recruited from their primary care or psychiatric clinic where they came seeking care. So the generalizability of Comet and SAMS is definitely higher than what it would be for Embark. So the first question that we wanted to look at was, how does irritability correlate with suicidal ideation at the same visit? Because of the clinical trial nature of this, we have now, for a same person, we have irritability and suicidal ideation measured at multiple time points, so baseline week 1, 2, 3, 4. So we can use a repeated measures way to then estimate the correlation over time, which allows us to get a more stable idea of correlation. So in the dark blue are the correlation between irritability and suicidal ideation, so 0.31, 0.73, 0.31. Again, because Embark is likely not reflective of real-world practices, but what's obvious here is that numerically the correlation between irritability and suicidal ideation was higher than any other correlation. Anxiety or suicidal ideation, insomnia or suicidal ideation, and other symptoms of depression. So I want to underscore that with depression, we took out the suicidal ideation item because one of the 9 symptoms of major depressive episode is SI. So we saw that these were at least the magnitude of association between irritability and suicidal ideation tended to be higher than the magnitude with other symptoms. Now, with the repeated measures way, we can actually include both irritability and depression in the same model to do a quote-unquote head-to-head comparison, and that's what we did here. So in these 3 studies, in 2 out of 3 studies, there was clearly the association between irritability and suicidal ideation was significantly stronger than the association between other depressive symptoms and suicidal ideation. But in all 3 studies, irritability was associated with suicidal ideation at the same visit, even after controlling for other symptoms of depression. We had a very similar finding in this 4th study now of individuals with stimulant use disorder who were doing a study of exercise. And here they were assessed up to 36 weeks. So the acute phase was 0 to 12 weeks, continuation phase was 12 to 36 weeks. And we found something similar that in the head-to-head comparison, the magnitude of association between irritability and suicidal ideation over this 36-week of follow-up was higher as compared to the magnitude of association between other depressive symptoms and suicidal ideation. So, that I hope it's at least in these 4 data sets, it was obvious that irritability was associated with suicidal ideation in the same visit. Now, as a clinician, for me, I want to know whether changes in irritability can help me prognosticate suicidal ideation in the future, because then irritability could be a modifiable feature that we can target for improving future suicidal ideation. So the way we structured these analyses was we looked at early change, so baseline to week 2, because I remember most of the changes were occurring early in the treatment, and then we predicted the levels of suicidal ideation from week 2 to week 8. And this is different from several models where we are often predicting remission at week 8, because we know that suicidal ideations tend to fluctuate. So if we are just looking at one visit, we may not capture the trend for a person. So that's why we wanted to look at levels over a several weeks period of time. And we stopped at week 8 because one of our studies only had 8 weeks of data. So we wanted our analyses to be set up similarly across the 3 studies. And what we found was that greater reduction in irritability from baseline to week 2, that delta, the higher the delta, that means the greater the reduction, the lower the level of suicidal ideation over the subsequent 6 weeks. So in 3 of these studies, the pattern was very similar, that greater reduction in irritability predicted lower levels of subsequent suicidal ideation. And what was interesting was that in 2 of these studies, in Embark and SAMS, the changes in depression was no longer significantly predictive after we controlled for changes in irritability. So again, suggesting that the link between irritability and suicidal ideation may be stronger than the link between our other symptoms of depression. Then in STRIDE, the 4th sample of adults with stimulant use disorder, we set it up as a similar analysis, except here we had data going up to 36 weeks, and we found something very similar, that greater reduction in irritability from baseline to week 2 was predicting lower levels of suicidal ideation, even from week 12 to 36 weeks. So that early change was predicting a stably lower level. Now, these can be interpreted the other ways also. The other interpretation could be those who had had worsening of irritability were more likely to have higher levels of suicidal ideation because the change could occur in either direction. So just to summarize things that this is where I would summarize all the clinically relevant discussion so far, that we have, at least you agree that irritability is associated with active suicidal ideation at the same visit. Baseline irritability predicts future levels of suicidal ideation, and greater reduction, early reduction in irritability may predict lower levels of subsequent suicidal ideation, raising this possibility that could irritability be a modifiable factor. So if I'm doing a suicide risk assessment, I'm seeing someone who has high irritability. By treating their irritability, could I lower their suicide risk? That still needs to be done. That's the next step of studies. Now, the challenge of doing that sort of study is, what are the treatments for irritability? Do we have, like, so for insomnia, we have specific treatments that are targeting just insomnia. Even for anxiety, we can say benzodiazepines are pretty good as anti-anxiety medications. Do we have similar treatments for irritability? And what is known is that there are only 2 medications with FDA-approved indication for irritability, and these are second-generation antipsychotic medication, and they're only approved in the context of autism spectrum disorder. So in pediatric studies, stimulants are often used to treat chronic and impairing irritability. There has been a study of a citalopram, an SSRI, added on to stimulant as being effective in reducing irritability. But we will discuss the off-label use of pretty much antidepressants over here. So in the studies that I've shown so far, in COMED trial, which was this randomized controlled trial comparing antidepressants versus combination versus monotherapy, even after we control for changes in depression severity, these medications still reduce irritability. So the antidepressant medication, as we know that their name is antidepressant, but they improve anxiety, apparently they improve irritability also, but the effect size of that improvement is on the medium to small side, 0.36, so not a big effect size. We see that in the Embark study, where we had a placebo-controlled trial, sertraline and SSRI reduced irritability significantly, even after as compared to placebo, and even after controlling for changes in depression severity. So it does seem like SSRIs do improve irritability even after we consider changes in depression severity. Is antipsychotic. So there was a study where brexpiprazole, it's a second-generation antipsychotic. It was added on to people who were on a stable antidepressant treatment and they hadn't improved with it. And adding brexpiprazole reduced their scores of irritability, but this was open label, so interpretation was limited. The only thing is that when they discontinued brexpiprazole, there was slight increase in irritability. So suggesting, but this could be discontinuation symptoms also. So this is not a high-grade evidence, but again, suggestive evidence. There was a study of pimavanserin. So pimavanserin is FDA approved for Parkinson's disease psychosis, and it's different from all other antipsychotics that we have, that it doesn't affect D2 receptor, so dopamine D2 receptor. And in a phase 2 study of pimavanserin in people with major depressive disorder, pimavanserin as compared to placebo was associated with greater improvements in irritability. Conflicts of interest disclosure, I was one of the site PIs for this study, so keeping that in mind. Ketamine has been studied now, and S enantiomer of ketamine is publicly available. So the study was done at Mount Sinai, where I worked from 2018 to 2021. And this was one of the first studies of ketamine for suicidal ideation. Interestingly, the study used the same measures, so CAST, irritability, and suicidal ideation, the measures that I've talked about so far. So this is the 5th study that had the same instrument, and that's why I looked at it. It was a small study, so only 12 people on ketamine, 12 on midazolam. Everyone had clinically significant suicidal ideation, so essentially people were inpatient or could have been inpatient and were seen on an outpatient basis. They were brought into the hospital for infusion. They stayed on the unit for at least 1 day, and then they were discharged. And the visits were structured like baseline, day 1, day 3, and day 7. So if you're familiar with ketamine-related research, usually the change in symptoms is much more rapid. So we measure more frequently as compared to antidepressant medications, where we measure every week because we expect improvement to take several weeks. So we wanted to look for ketamine versus midazolam changes in irritability. And then we also wanted to see how do changes in irritability and suicidal ideation relate to each other. So this is the graph of changes in irritability with ketamine versus midazolam, and the D is the Cohen's d effect size. So within a day, there is a big difference between ketamine versus midazolam in improving symptoms of irritability, and this effect size is much more as compared to what we saw even after 8 weeks of treatment in sertraline versus placebo. So the ketamine leads to a big improvement, and then that improvement is sustained for at least about a week. That was the last data that was collected from that study. So ketamine could be a drug that can rapidly induce improvement in irritability. And then this got cut off, but it was about 0.7. And the baseline to day 7 change in irritability was significantly correlated with baseline to day 7 changes in suicidal ideation. So this is now 5th data set where we find that irritability and changes in irritability are related to changes in symptoms of suicidal ideation. There was another paper published last year where they looked at individuals who were coming in for clinical treatment with ketamine and how did ketamine improve symptoms of irritability. This was using a single item of GAD-7, 7-item generalized anxiety disorder scale. And there are also people who started with irritability at baseline. They had reduction in irritability. Those who didn't have significant irritability at baseline sort of had a stable level. We have unpublished data from a couple more other studies where we showed that ketamine improved irritability as compared to either midazolam data from an NIH-funded study or saline, which was the competitor used in studies done at NIMH. So we showed that this would be relevant when I talk about my the study that we are doing right now. So I'm just checking how much time I have. So now switching to neurocircuit mechanisms of irritability. So a lot of work has been done in the pediatric imaging space. So especially work done at National Institute of Mental Health, led by Ellen Levenluft and her group. And what it has been, this is a figure from a recent review article where really what's implicated are circuits involved in aberrant threat processing and aberrant reward processing. So both of those circuits, and even in their work, striatum, this big region, seems to be implicated in these different studies. What is obvious is that there haven't been any studies of irritability in adults with major depressive disorder. So that people who are earlier in the career, if you're thinking of like a future where you want to go to a place that no one else has worked at, and for which others have developed tools, right? So you can use pediatric tools in adult studies and get away with it. So just a quick information about Embark Study. So Embark was this multi-site, 4-site study where people with depression were recruited. So these were symptomatic volunteers. They came in and they had a pretty extensive battery of EEG, MRI, behavioral assessment, clinical phenotyping, and then they were randomized to either treatment with sertraline or placebo. So Cherise, who was a student at UTD at that time, started working with the resting state data from Embark Study. So Cherise is, and her face is right there in the corner. Cherise started working with Embark resting state data and really took the approach of, instead of using like a voxel-wise approach, she used a parcel-based approach, so dividing the cortex into 100 regions. Again, this is based on published Schaeffer Atlas, and then 21 regions from subcortical region. And so there are now 121 region, and there is a matrix of 121 by 121, because in resting state, you are computing the connectivity between 2 regions. So now there are 7,260 functional connectivity pairs. So Cherise, in her paper that was published in American Journal a couple of years ago now, she looked at this functional connectivity matrix to predict improvement in depression with sertraline versus placebo. So again, the method she had developed was easily available to us. What we just looked at was the symptoms of irritability. So at baseline, how does these brain connectivity features relate to symptoms of irritability? The problem we had was that the number of people on whom we had data, which is about 270 some people, that was far less than the connectivity features that we have. So she used an ElasticNet model. So ElasticNet allows us to just look at those features that were related to irritability and then use the canonical correlation really to get the best guess out of this data set, that what is the best estimate of how does the symptom of irritability relate to these functional connectivity features. So looking at the results, so this is just a high level. The best guess is that these functional connectivity features from about 76 regions, I think, in the brain were accounted for about 60 to 70% of variance in the symptoms of irritability. What was more interesting was that we can just estimate that what is the likelihood of a region being retained in the elastic net by chance versus how much they actually got retained. So that was the ratio we computed. And when we looked at what regions were included, what was really interesting was that those with a higher likelihood, regions in striatum were more likely to be retained by ElasticNet as compared to even regions within default mode network or hippocampus. What was really interesting, and I think it got cut off in this figure, was that the limbic regions in striatum were actually not retained. So these were not the regions we typically associate with very strongly with emotion regulation. These were more like motor aspects of our functioning that were retained in there. So that was a key finding that served as the informing the hypothesis that even in adults, studying the function of striatum would be helpful. Now, in terms of like which other brain region that we wanted to look at, we did look at habenula as a region of interest. And just a brief detour, the reason we looked at it was because habenula signals negative reward prediction error, so lateral habenula specifically across different organisms. When we are expecting a reward, so like paycheck on the first of the month, and I go and check my bank account and it's not there, I would have some a negative reward prediction error, right? So frustration also, and that is typically signaled through lateral habenula. So we know that it has that role through evolutionarily conserved role. And then preclinical studies have also shown that when we activate lateral habenula projections, in response to frustration, there is increased activation of lateral habenula projections, and which in turn increase motor activity. So those are where the key findings. Now, the challenge with habenula is that it is a very small region. So, okay, so my cursor. So I'll try to show it here. So it literally had to be segmented out manually, and you have to like peer really closely to see this white dot over here, which and the feature of that is that habenula has greater white matter content as compared to surrounding thalamus. So it creates a slightly higher contrast. And that along with anatomical features has been used to define this region of habenula. So in 37 people from Embark Study, so 37 healthy control, Charisse manually segmented out this habenula region. So she did all the work. And what we then did was we computed the connectivity, functional connectivity between these, the bilateral regions of interest of habenula with those striatum regions that I just showed you. And what we found in healthy controls was that the symptoms of irritability, and again, there is some distribution that you see in the scores of symptoms of irritability, and we saw that there was a significant correlation between some habenular region, striatal regions and habenula functional connectivity. So that's why we then are now using an automated segmentation approach for habenula. That is basically everyone gets a T1 scan and a T2 scan, and creating a ratio of that T1 to T2 has been shown to be useful in manually, automatically segmenting out habenula. So that's a method that was developed by Gordon Zhu when he was at Mount Sinai, and he's one of the consultants on our project, and he's now at Baylor College of Medicine. Yeah. So on each side is about 16 to 20 millimeter cube. So the total is that like 32 to 40 millimeter cube. So it's really like, so you initially when I wrote the grant, I would come to it, it was using a 70 scanner because like ultra high field would have the advantage there where you can really lower even the voxel size of functional MRI. But when I moved here to UT Southwestern from Mount Sinai, our 70 scanner is not set up to do functional MRI yet. So we switched over to 3D.
But so the functional data that you're looking at here qualifies as 3D?
Yeah, yeah. So that's why it's not published, right? so it's preliminary data. Yeah, so Cherise is looking at data from the Human Connectome project where they didn't have a measure of irritability per se, but the anger was assessed using the toolbox, NIH toolbox for anger dimensions. And there, I think about 200 people also have 70 fMRI data. So she is building this body of work there using Human Connectome project young adult studies. So.
And then, I mean, because the correlation looks strong, right? Because I think you said the connectivity between the habenula and regions of the striatum. So is what's happening here, you've identified number of voxels in the striatum,
yeah,
showing its statistically significant correlation with your habenula ROI, and you've just scatter plotted that specific relationship?
Yeah, so it's not that, so the striatum was parcellated based on the like 7 cortical connectivity. So it wasn't just looking at voxels in striatum, but the striatum was segmented out based on which major like canonical network in the cortex that it mapped down to. So the connectivity was between the bilateral seed and habenula to that parcel in the striatum. So that functional connectivity is plotted out in this axis, and then symptom of irritability is on this axis. So the second aspect was that all of the data that we have presented so far, or at least our pilot data, was all in the context of resting state circuitry, and how do we go about doing a task for irritability that was the next challenge. And that's where we benefited from working in the with like Ellen Liebenluft at NIMH, who has used certain tasks. So this is basically the task, and I hope no one here is now going to participate in our study because it is a rigged task. The way the task works is that it's a very simple game where there is a cue and there is like where the stimulus is presented, and you have to just choose left or right. And sometimes it comes on the same side as the blue circle, and sometimes on the other side. And if you get it right, you get 50 cents per trial. So people earn like, well, you can earn up to $50 at the end of the first non-rigged game. Then in the scanner, they get the rigged game, where even when they are right, 60% of the times they are told that you're too slow, and they start losing the money. So because for wrong, they lose the money, and that induces a lot of frustration. And so we have there has been an adult version of this study that was done outside the scanner using EEG, but there hasn't been an adult version of this study. So it still remains to be seen how frustrated adults get. Kids definitely get frustrated doing this task. And the good thing about this task was that there was a study in Ellen's group where they did test retests. So they basically had people come in, do this task, and then had them come back again after 2 weeks and do it again. And the debriefing was after the second task, so they found out after the second task. So it was feasible to do, and people still got frustrated. So they have to rate how frustrated they became. So even playing the same game after 2 weeks was quite frustrating. So
the adult version of the study called Submitting Your Grant.
yeah. Yeah, or submitting, yeah, a paper, yeah. So,
It's like cute discrimination with a twist.
yeah. So we will start scanning people with this task. We'll soon. So I'll skip over to this. So I'll just talk about the. Okay, so this is the study that NIMH has funded for us, where really what we are trying to do start off with is understand what are the neurocircuit mechanisms of irritability in adults. And the aim one is just cross-sectional, where we look at the circuits we think were important, the striatum habenula circuit or this task, and how it relates across. And we used MDD because irritability, even though it's transdiagnostic, irritability in a manic person is likely different from what it is in an unipolar depression. So that's where we restricted it. And so everyone comes in and they get a scan. And for healthy controls, that's the only scan they get. For adults with depression, they get treated for 2 weeks with either ketamine or midazolam. So it's a randomized control trial where people would not know what they're getting. I would be running the infusion. I wouldn't know what they're getting. And at the end of 2 weeks, then they come back for a repeat MRI session. So the scans that we acquire at AIM-1 would be again acquired at AIM-2. The advantage of using ketamine is that we have a much shorter time period over which we can reliably, so at least hopefully change symptoms of irritability as compared to treating with antidepressant medications, which tend to take much longer. So any questions about this? And then this sort of like fits into a bigger sort of like scheme of things for us, where we want to look at clinical symptoms, so symptoms of irritability, aggression, how it relates to suicidal ideation behavior, but also on neurocircuit mechanisms. So starting with some difficult to image regions such as habenula, but also looking at aberrant responsing. So we started with reward processing, so skewed reward processing, but we also want to start incorporating threat processing tasks because they have been linked to irritability in the past. And the goal is to then develop new treatments. As we know, this is the experimental medicine paradigm, that when we know the circuits, we have a better idea. What I skipped over is that preclinical studies and even some human studies suggest that ketamine affects the function of habenula. So again, human studies, difficult to locate, but preclinical studies have shown that ketamine reduces the burst firing in habenula, and that is important in antidepressant-like effect. And then we also want to improve patient outcomes as we are doing this. So that's why we are also we are developing those calculators and tools so that people don't have to wait for the end of our phase 3 study to start using these findings in clinical care, but rather could start incorporating assessing irritability as we go along. So most of the work that I presented, all of the work that I presented is a team effort. So most of the data are from studies led by Dr. Dr. Trivedi here at UT Southwestern in Dallas, and Abu Minhajuddin is the statistician who analyzed all the data. Sharice did all the neuroimaging related work. Then the team at Mount Sinai that helped me think it through from the experimental medicine paradigm, and then really indebted to Ellen at NIMH because her work in pediatric irritability served as sort of like the basis on which I could build an adult-related work. So again, early career, that's often key, that if you can get good role models, you can fashion your own work around that, and then all the participants that we talked about in this presentation. So I'll stop for questions. I can stop sharing screen.
Yeah, just leave it.
Okay.
It's easier. Yeah, thank you.
So I guess a kind of big picture question, which is, it's quite clear. I mean, the relationship between irritability and suicidal ideation and the time and the appropriate timing makes it clear that there's a very interesting relationship there, but that's essentially observation. What is the mechanism that's linking irritability specifically to suicidal ideation and presumably, in some cases, actual attempted suicide?
Yeah, so why is irritability linked to suicidal ideation? Could be taught in two ways, right? So irritability is a feature, suicidal ideation is a syndromic manifestation that we are seeing, and there could be underlying like neurocircuit mechanisms. So for example, one aspect is that irritability may be associated with increased expectation of reward, right? So even when you are not expecting reward and you should not be expecting and you are expecting it, and then you get disappointed more easily. So that common mechanism could link to that sort of like a heightened emotion dysregulation. So irritability is a feature of that, right? So you like there is greater dysregulation of emotions that we know predispose to suicidal behavior. So disorders where there is greater dysregulation of emotion in general, like borderline personality disorders, are also linked to suicidal ideation itself. So that sort of undercuts my whole pitch that irritability by itself is a unique feature. It could just be that it's linking. Why irritability itself? I think, a lot of caveats to that finding. One is that these are all adult studies, are all self-report, right? And the measure of self-reported irritability could be very different from an observer-reported irritability, right? So we don't have that piece in an adult study, but it could be that it's like irritability tends to be more activating, like it's sort of like a more active emotion as compared to anxiety, which would be more withdrawing kind of like at least experience. So that could be part of it. Like if it's more of like an aberrant approach behaviors, then approaching those suicidal ideation related behaviors could also be occurring. Again, these are like very, we don't know that. I mean, I think we'll have to, yeah.
So I just wanted to just follow up on that. Yeah. So the reason I asked that question is I think it's important because there's a gigantic difference between some kind of behavioral feature, self-reported or whatever feature, predicting something, and it giving you any kind of clue to a causal mechanism. So it could be that irritability is a great predictor of suicidal ideation, for the first reason that you said. But it could be barking up completely the wrong tree to think that understanding the neural circuits underlying irritability is going to tell you anything about the neural circuits that underlie suicidal ideation. It's a correlation.
Yeah.
So it seems to me that implicit in what you were saying is that there is some kind of causal relationship that is mediated by some kind of common neural circuit. So what I'm trying to get at is what is the evidence for that?
I don't think there is any evidence. So we haven't. And I'll get to that. So the part about irritability linking to suicidal ideation has been squarely in the clinical realm. We are not trying to even probe it in the neuroimaging realm, because suicidal ideation, first we'll have to go and recruit a sample where there is higher prevalence of suicidal ideation, because in regular studies that tends to be less prevalent occurrence. And we'll actually have to do a study in which even behaviors have occurred. So we'll have to enrich for that. So that is not like a neuroimaging question that we are even seeking to address. For now, we are staying in these are like clinically relevant findings that may inform clinical care. But first, we need to even understand what is irritability and can we develop treatments that can target specifically irritability.
This is a follow-up to Mick's question, and Mick would be able to say better than me. But I was thinking, instead of looking at brain structure or connectivity the way you're looking, wouldn't it be better to look at if irritability and suicidal ideation is mediated through error-related negativity in this kind of task that you're discovering and talking about? And again, as I said, Mick knows more about the EG. I don't know much about it, so Mick can correct me if I'm wrong. But I was thinking about this whole idea that if you have this high expectation and then you have this response, should you see this high ERN kind of response, and then whether the ERN reduces with the drug treatment? Just a grand idea.
Yeah, I mean, I mean, we started with just like staying with irritability, because when we, grant idea also, like if we go about like shared mechanisms between irritability and suicidal ideation, right? Suicidality is a very broad term, which we will have to narrow it down. It would lead to a lot of like controversy around that, like why not this circuit or why not this task, especially in the suicidal ideation realm. And then we are bringing in uncertainty. So we started off with at least focusing on one aspect that no one else has studied in adults, right? So that's where it became. But you're right, like that would be.
And as you need, you do the same
Yeah,
task.
and it would be a missed opportunity on our end if we don't get like some EEG or something else on these people as they run through. So what we are planning to do is that Dr. Trivedi has an ongoing study which is recruiting people for and has like a multimodal Texas resilience against depression. So we'll try to, as much as possible, enroll our people in that also, so that there is like a separate study from which some of this pilot data can be collected that we can see.
So, just thinking about other possible ways of probing the underlying neurocircuitry, do you know if there's any phenotypes that are associated with irritability? So, like, first thing I thought about was like startle reflex. Do you know if any other features that you might be able to track?
Yeah, I don't think that has been studied much, the startle reflex, but that's a good thought, right? So, yeah.
Yeah, I think I maybe have a related question. I noticed in the way that you're measuring irritability, it seems like many of the questions are social in nature, like I don't want other people bothering me, or I don't want to interact with people. And I was thinking about how much of this is this irritability is social in nature versus just being more sensitive in general or non-social.
So that's a great point, because when we think in medicine, often irritability is conceptualized as increased sensitivity, right? So even our definition could be thought of like that increased sensitivity to respond with anger when we say low threshold. So like irritable bowel syndrome is right, like that's in medicine. That's so yeah. So assessing like startle reflex or other would be an important consideration. So
Did you touch on temperature sensitivity?
Yeah, I don't think
cortisol level. Yeah.
Yeah, we never wrote any blood collection guideline here, so I think we'll have to rely on the TRAD for collecting blood. It becomes like writing a clinical trial protocol becomes very challenging the more you add to it. So, but yeah, that is a very valid point, and is a conceptualization of irritability, that it's increased sensitivity in certain ways. I also want to say that we know that our assessment of irritability is incomplete because we are not assessing any like observer reported, right? In pediatric literature, there is the parent reported or the caregiver reported. You can even get it from teachers. Nothing comparable exists in adults. So anyone who wants to take on that challenge, I'm very happy to think it through and work along with it.
Yeah.
Okay. Yeah.
Yeah, listening. So, I mean, because you conceptualize, you're really, it's good that you pointed out that it's not directly assessed in the general depression inventories.
Yeah.
But have you just done a straight factor analysis, including the irritability measures, plus all the other things you typically measure?
So these 5 items came out of that sort of a factor analysis. So it was a 17-item scale that Trivedi had developed to assess like activation syndrome related features. So these 5 sort of like stuck together.
Well, that means you do the analysis including all the items in CSD.
Yeah. I think we haven't done that, but these will probably stick together. When we look at the loading structure, they often, all these items often pretty strongly go together.
I'm wondering more whether they stick with anything else that you would typically do. Like, are they all correlated to?
So they would stick better with anxiety-related features. So, and in pediatric study, again, Ellen's one of her postdoc now, staff scientists, did look at these like overlap with anxiety symptoms, so like shared versus unique overlap. So you can like use a bifactor to decompose that association. So we know that anxiety would definitely be related to. It's not related to symptoms of anhedonia, at least. That's what we have seen.
So then in the analysis you presented, if you, rather than comparing it to the depression inventory analyzed as whole, what if you just analyzed it relative to anxiety?
Yeah, we did, and it was still significant. Yeah, we had reviewers asking us the same question, so we did that. We actually even had a reviewer who said that one of the items was more similar to impulsivity, so take it out, and it was the findings were still the same. I mean, I think like even with impulsivity, there is overlap. So I don't think that we are just looking at pieces of the pie when we are looking at any one feature, but yeah. So.
going to ask you my questions in a minute.
Okay.
After, just to save time. And then I'm going to ask the voice in the sky if there are any online questions.
I have one question.
Okay.
All right, it says, excellent presentation. You presented data from COMED, Embark, SAMS. START is the largest ever study in depression led by UTSW. You did not include your data analysis. Please comment. I hope that makes sense.
Yeah,
STAR D, sorry.
Sequence treatment alternatives to relieve depression. That is the largest depression pharmacotherapy study to date in depression, led by John Rush and Trivedi here in Dallas. The challenge with STAR-D was that it has IDS, which has a single item for irritability, but it does not have the same irritability scale. So STAR-D was, I think, 2001 to 2005 when the STAR-D recruitment actually occurred. The scale that Trivedi developed was in 2007. So just timeline-wise, we missed out. Trust me. Like I do the fact that I don't have the same rating scales from there. The single item could be looked at. It has been looked at a little bit in STAR-D, but we never went into looking at analyzing data based on just a single item. So.
All right. Thank you very much for the talk. Thank everyone for attending. Give our appreciation.